This is Jeff Geske with the FITsontheGo blog. I'm here with Dr. Horng Chen, who just presented the ROSE-AHF trial. Dr. Chen, thank you for joining us, and congratulations on a trial well done.
Thank you. Thank you.
For those fellows who were unable to join us here at AHA to hear the trial results, would you mind giving us just a brief synopsis so they can hear some of the exciting science that you've discovered?
Definitely. There are a lot of patients with acute heart failure that have renal dysfunction, and these patients are at risk for inadequate decongestion or worsening renal function during therapy for acute heart failure. And both those factors are associated with worse clinical outcomes. Currently, there's no FDA-approved therapy to enhance renal function in patients with acute heart failure, and hence the ROSE-AHF study was actually designed to test two drugs which we use clinically, which previous studies, small studies, have shown that low-dose dopamine may be renal-specific and may enhance the kidney function in acute heart failure. And despite the fact that the ASCEND study showed that standard dose neceritide does not have favorable effects on renal function and may be hypotensive, we and others have shown in small studies that if you use a low dose neceritide and which decrease the hypotensive effects, we may have renal preferential effects actually. So the ROSE-AHF study was actually designed to test two independent hypotheses that in patients with acute heart failure and renal dysfunction, we hypothesized that the addition of low-dose dopamine or low-dose neceritide would improve urine output and preserve renal function as compared to standard therapy. So all the patients receive standardized diuretic dosing for the first 24 hours, and that's 2.5 times the outpatient dose, and this was based on the DOSE study.
Sure.
I should state that the dose of dopamine we use is 2 micrograms per kilogram per minute, so that's considered as low dose. And for the neceritide, we use 0.005 micrograms per kilogram per minute without the bolus.
Sure.
So we enrolled a total of 360 patients, and our core primary endpoints is cumulative urine volume at 72 hours as a measure of decongestion, and plasma cystatin C as a measure of renal function. So unfortunately, our hypotheses were wrong, and we did not see favorable effects with either low-dose dopamine or low-dose neceritide as compared to placebo with regards to the core primary endpoints of 72-hour urine volume or change in cystatin C.
It's a great trial design, how you were able to do two different studies essentially as part of one. With using a common placebo group. I think that's great. Knowing the results now, how do you see this altering your clinical practice?
Yeah, but I think the main take-home message of the ROSE study is that despite the notion that low-dose dopamine may be renal-specific or low-dose neceritide may be renal-specific, we saw in this study that they are actually not renal specific. In patients who received low-dose dopamine, there were increased incidence of tachycardia, and there was less incidence of hypotension. Similarly, in patients that received neceritide, there were a trend for increased incidence of hypotension as well. So the main take-home message would be that these medications should not be used routinely in all patients with the intention that you would preserve renal function or enhance diuresis.
Great. Thank you very much. Now, moving forward, what do you see kind of on the horizon, and how can fellows like us on the FIT blog or around the country, how can we be involved in exciting research like this?
Yes. So, one point that I do want to make is that just because of our negative results from the ROSE study, it doesn't mean that we have no use for dopamine or neceritide.
Sure.
When what it tells us is, when you have a heart failure patient, depending on how the patient presents, and you might have to decide which of the medication may be useful. And a good example would be if you have a patient who is hypotensive and really congested, low-dose dopamine may still be useful to maintain blood pressure in that case scenario. On the contrary, if you have a patient who's really decongested, really dyspneic with high blood pressure, IV vasodilator may be useful, and you could consider using nitroglycerin or neceritide actually. Now, as we move ahead with future clinical trials in acute heart failure, I think one of the lessons that we learned from ROSE-AHF study is that we did find that there was suggestion of differential response according to ejection fraction. So the patients with preserved ejection fraction have the different response to patients with reduced ejection fraction. Of course, the ROSE study was not powered to look at those differentiation. But I think as we move ahead with future studies, we might really consider doing studies targeting these subgroups of patients or have enough power to look at these subgroups, because acute heart failure is such a heterogeneous group of patients. And it's important for fellows to be involved in research, and the NHLBI Heart Failure Research Network, we actively support fellows. In fact, 3 centers out of the 9 have a separate grant that helps us train fellows in clinical research, and they're actively involved in our discussion. They're encouraged to design sub-studies, write method papers, and so I think a good way for a fellow to be involved in research is to think of sub-studies when the primary endpoints are done, because there's a wealth of information in all these clinical trials that are being done, and a lot of information may not be tapped actually, and it's really not tremendously expensive, or you don't need a lot of financial support to do sub-studies, and I think it's something that fellows can easily do.
Great. It sounds like there's a lot of room for fellows to look at those subgroup analysis and really determine which subgroups might benefit from this therapy, even though the trial as a whole showed no benefit with regards to the primary endpoint.
And even though we're not powered, those would be hypothesis generating. Yep.
Well, great. Thank you so much for joining us, Dr. Chen. This is Jeffrey Geske with the FITsontheGo blog. You can find more news and interviews from here at AHA in Dallas by going to www.youtube.com/FITsontheGo.